Okay, hello everyone, I'm Mark, and I did treatment of chronic subluxing patella. So I'll start off with anatomy. You have patella right here, you have femur, and this is a right leg of a person. This is tibia, you have the fibula. I'll be focusing on the patella, which sits in the patellofemoral groove right over the front of the femur. Patella sits in the femur through the quadriceps tendon and the patellar tendon. Patellar tendon's this one right here, underneath the patella, and the quadriceps is attaching it to the quadriceps muscle above. So a little bit more with anatomy. We have the muscular structure. So this is quadriceps group. Again, this is a quadriceps tendon, patellar tendon. This is the patella. Around the patella, you have the medial and lateral retinaculum, which can cause some of the instability that I'll be talking about. And this picture is a little blurry, but basically what it shows is the patella is down here when it's disconnected from the quadriceps tendon, and the patella would sit right in this groove right here, if you can see it. Because I'm doing patellar instability, I looked a little bit at the biomechanics of a kicking motion. I'm doing a soccer player, so first you have the approach where they're leading up to the kick. Then you have the swing limb loading where they bring the leg back, and then you have your plant leg. Next is hip flexion with knee extension, ground contact, and you have the follow through. Patellar instability. So patellar motion is mainly caused from quadriceps muscle contracting and relaxing. Common mechanisms for subluxations happen when the knee is partially flexed with a position of external valgus or rotational forces. So in this case, if I go back, the plant leg is where the instability was for the athlete. He planted and rotated, and the patella popped out. For some individuals, their patella will not sit in the groove well, and it puts the person at a greater risk for the knee to sublux or dislocate. So some predisposing conditions, like I just mentioned, the patella won't sit in the groove. So if this is a normal patella and it has to sit in the groove right here, you have patella baja where it sits lower than it's supposed to be, or patella alta. Patella alta can be caused from either overdeveloped quadriceps or just maybe they have some tight quadriceps muscles. They can also be predisposed if they have a higher Q angle. This is just another picture of what it looks like when the knee is either sublux, so it comes out, comes back in, or it stays dislocated. So the case study, this was a male college freshman. I didn't give him a name. He was injured during his first preseason college soccer game. He kicked a ball and fell to the ground in pain. He did have previous history of subluxation, so he had a lot of subluxations in that specific plant leg. He did not have any in his kicking leg. The high school athletic trainer had him do exercises to strengthen his knee, but he didn't do any physical therapy outside of the school. The athlete's kneecap would pop in and out, but the athlete believed that it would not happen again just because he completed, and most athletes, when they complete their rehab, they're like, this isn't going to happen. He didn't wear any sort of bracing. And so on the initial examination, a sideline examination was given. Ligaments were all in place, or not all in place. There was no laxity on the ligaments. There was swelling that started to form. Athlete didn't want to move the knee. They didn't want to motion. And that's when they told me at least about the previous subluxations that happened. Day after injury, they were partial weight bearing, they still had some pain. More in-depth eval was done. This is when I did the apprehension test and jerk test. Apprehension test, you could move the patella out and back in of the femoral groove. Jerk test was done, same thing. It showed signs of knee instability. Because there was swelling, it was hard to tell, but they did have patella alta, so they naturally just had their patellas riding a little bit higher than normal on that one leg. And it was shown bilaterally. But like I said, they didn't have, in their kicking leg, they didn't have any subluxations to date. Because of the positive testings, they were sent to orthopedic doctor. Same thing, he did the apprehension test and this was positive. He ordered MRI to confirm his findings. He presented surgical and non-surgical options. So for non-surgical, usually a surgeon or doctor is going to want to do non-surgical first. Because of this person's history, they didn't want to take the conservative approach. The non-surgical options would have been tightening or working on the muscles around the knee to try and strengthen them so that possibly the patella can be a little more stable. But because of the person's previous history, they decided to do the surgical option. With surgical options, there's a few different options. There's the MPFL surgery, which is the medial patellofemoral ligament surgery, and they'll actually graft it from somewhere else and replace it if it was torn. In this case, they decided just to do a lateral release, just to release the patella into a better spot and then tighten the MPFL. So this is what the plan was going to look like. It's going to be some prehab surgery, then rehabilitation, and return to play was going to be 6 to 12 months. Some surgery goals, like I said, they were going to do the lateral release, involve the cutting of the ligament. If the patella returns to the natural position, the kneecap can then move correctly through the groove. When there's tension in the retinaculum, or when it's released, the kneecap is allowed to drift medially, and then from there we'll just tighten that area. And then hopefully this doesn't screw everything up, but this is just a basic video of the surgery. I don't know if it'll be...
Lateral release and medial imbrication. This procedure is designed to loosen or tighten ligaments on either side of the patella, the kneecap, to improve the movement of the patella in patients suffering from patellar tracking disorder. This procedure is usually performed arthroscopically through 1 or 2 small incisions near the patella. Through the arthroscope, the surgeon cuts the lateral retinaculum. This relieves the tightness, decreases the lateral pull on the patella, and allows the kneecap to move correctly within the femoral groove again. The surgeon may also use sutures to tighten the attachments on the other side of the knee. After the surgery, incisions are closed. Following surgery, crutches may be necessary for several days, and physical therapy is prescribed.
So like I said, you could see that they released and then they tightened on the surgery. So some of the prehab that was done was just some simple biking, quad sets where they just contract the quads. Heel slides just to improve that range of motion because the range of motion was kind of limited with all that swelling. Some straight leg raises, hip extensions, some TKEs where there was a TheraBand wrapped around their knee and they were just trying to extend that knee. We also worked some VMO exercises because they were having tightness, their patella was riding high. I wanted to do some VMO exercises for the vastus medialis oblique, which is the inside quadriceps muscle, and that was to hopefully start working the patella into a better location. Surgery took place 4 weeks after the injury occurred, and the athlete completed 3 weeks of prehab before that. Like the video said, it was done arthroscopically with 1 or 2 incisions. The surgeon did determine that he wanted to tighten the medial ligament, so he ended up doing the medial imbrication surgery. Again, this is just a little overview of the surgery. Post-op rehabilitation started 1 week post-operation. Initial rehab goals were to control the pain and inflammation and improve knee range of motion. Also wanted to protect the healing of all the soft tissue structures because there was cutting and fastening down involved. And then quadricep muscle re-education. So phase 1 of rehab, some of the goals were to control pain and inflammation, improve knee range of motion, like I said, increase strength. Some of the criteria to advance to the next phase, the athlete had to have the ability to perform a good quad set, so I wanted to make sure that the quad was firing. They had to also have approximately 90 degrees of active knee flexion. During this phase, they weren't allowed to do any sort of straight leg raises, just because they didn't want anything that was either loosened or tightened to be screwed up when they were doing like open chain exercise. During phase 2, this was 3 to 4 weeks after surgery, weight bearing was tolerated. Again, this was more of like quad sets, some biofeedback was done. Hip, ab, and adduction exercises. Again, we went back to the TKE, straight leg raises. Some of the goals for this were to increase flexion range of motion and have adequate quad and VMO contraction. For this stage, they were also still at 90 degrees of flexion, but we wanted to work on having them get back to more of a normal gait. And they had to get cleared by a physician to begin more concentrated closed kinetic chain program exercises. For the rehab phase 3, this happened 4 to 6 weeks after surgery, and we started getting into more of wall squats and balance and proprioception activities. We were looking to make sure that they had no evidence of patellar instability. The surgery up to this point had worked. No patellar, femoral, or soft tissue complaints. During this whole rehab process, I want to make sure to, because they had the predisposing condition in the other leg, to make sure that we were working both legs in the rehab process. Now we get more into the strengthening phase 4, and then the strengthening phase. For this was 6 to 12 weeks after surgery and 3 to 6 months after surgery. A lot of the same exercises, just kind of ramped up, more balance training, more functional training. One of the exercises like toe taps on the wall. You have like a ball and then you just have them kind of rotate their feet, try and see how many taps they can get on the soccer ball. Had them do ladders, had them do some plyometric bounding. And then as far as getting into more of the functional or sport specific, they were doing dribbling soccer balls and kicking progressions. Kicking progressions are similar to like throwing progressions where you don't want to start them off just kicking as hard or as far as they can right off the bat. So started off with just kicking back and forth about 10 to 15 feet and worked their way up from there. Return to play guidelines. Made sure that they had no pain, no patellofemoral instability. They had full range of motion back up to where they were before, and they were able to kick a soccer ball pain-free. The athlete was able to complete the return to play process in 7 months, and like I said, it takes anywhere from 6 to 12. They were able to do it a little bit faster, and I think it's just because they were an athlete and didn't have a sedentary lifestyle. And then questions.
Are there any long-term complications that can go along with chronic patellar subluxations?
I think if you don't fix it, there is. I think if you're able to tighten it or fix whatever's going on, you won't necessarily have the long-term implications. Let me rephrase that also. I think if you have an increased Q angle, which I talked about, that's another way. I think long-term wise, it can put more stress and things on your patella, and so that's where a surgery might not last that long. It might only last 6, 7, 8 years, something like that. That answered it, sort of.
Are there any like massive differences when you're doing the surgery when there's the lateral release versus the medial tightening? I don't know, like one, would you ever do those together if somebody had major issues? 2, is the medial tightening like a longer, shorter rehab process, anything than the lateral release?
So the first question was,
Like the
do you do them
differences.
together or do you do them separately? Is that what?
Yeah, we'll start with that.
Okay. So the medial imbrication isn't always done. Lateral release is